I think we just need prospective data, right? So, you know, there's a decent number of patients whose disease progresses after the first line options, who are still fit enough to, you know, to try at least one other option. Now, in the absence of a trial, we have lots of, you know, choices these days because there's lots of approved regimens and we can use them in a quote unquote off-label way, right? Even though many of these regimens were studied in the first line setting, you know, Tezo-Bev, Durva-Tremi, we can use one after the other, for example, if there's not a dose-limiting toxicity for immune therapy, for example. It is a very common maneuver to just use lenvatinib after frontline immune therapy and then go from there. But certainly, you know, to answer these questions in the modern immune therapy first era, we just need prospective data to tell us, to guide us. So, you know, we do have a decent number of second line studies these days. For example, we have approaches combining alternative dual immune therapy approaches. For example, anti-PD-1 plus anti-TGF beta pathway. That's a strategy which we have a trial for here. We have kind of more precision medicine approaches for novel strategies to target, for example, beta-catenin-driven tumors, which is about 1/3 of HCC. We also have strategies to target c-Myc, which is an oncogene that drives a decent proportion of HCC, although perhaps not in a genomically identifiable way, at least not yet. We're working for biomarkers there too. So there's lots of second line and beyond studies that are ongoing now that should provide some good data moving forward.